All right. Good morning, everybody. Thank you for being here. To those in the room and also online. My name is Lisa Emerson, and I'm the Senior Policy Advisor for the Division of Financial Regulation, and I'll be the hearing officer for today's hearing to adopt OAR, Oregon Administrative Rule 836-053-0441, which sets requirements for health benefit plans covering gender affirming treatment services. This rule aims to ensure equitable access to gender affirming treatment, mandating that medically necessary gender affirming procedures are covered without reasonable barriers. The rule establishes requirements for utilization review, standards, qualifications for reviewing providers, and outlines the specific coverage standards according to the accepted care guidelines from the World Professional Association for Transgender Health, WPATH, Standards of Care, version 8. Also in attendance is Karen Winkle, the Division Rules Coordinator, who is recording today's hearing, and also Jesse O'Brien, Policy Section Manager with UCDS. And we'll go through introductions here in a moment. So today is Tuesday, November 19th, 2024. The time is 11:04 a.m. Pacific time. This public hearing is being conducted in a hybrid format through Microsoft Teams and also in the Labor and Industries Building in Conference Room A, located in Salem, Oregon. We will begin with introductions of who's here for the public hearing. And please, when you introduce yourself, please state your name, your affiliation, and whether you would like to testify today, provide oral testimony. For those joining by Teams, it would be helpful if you could please put your name, affiliation, and whether you would like to testify, provide oral testimony in the chat. That will help us organize public testimony, make sure we allow, we budget time for that. So let's see. So let's start with the folks in the room. Let's go around the room, and if you'd like to please introduce yourself, why don't we start over here? Name and who you're with, and if you'd like to provide any oral testimony today.
My name is Justine Netterling-Crair. I'm from Washington State, and I am the founder of a medical watchdog organization called Gender Health Query for lesbian, gay, and bisexual people.
Are you interested in providing any oral testimony today?
Yes, ma'am.
Okay. So, and please go ahead.
I'm Holly Harrington. I live in Salem. I'm not representing any organization, but I am the parent of a trans-identified teen. And I will not be testifying because I've already submitted my testimony.
Okay. Thank you.
My name is Jamie Reed. I'm the Executive Director of the LGBT Courage Coalition, a national coalition, which has retained representation in this matter, and I will be testifying publicly today.
I'm Jake Thomas. I'm with the Lund Report, and I will not be testifying.
Okay.
Yeah, Clemmeyer, DCBS. I will not be testifying today.
Thank you for being here. And if I could just come back.
Yes, Brett Elbegard. I'm an attorney. I've been retained by James organization.
And would you like to provide any
No,
testimony? Okay.
just lurking.
And could I please get your name again?
Justine Craig.
Justine. Very good. And keep ourselves organized here. Thanks. All right. Let's go down the line. We're going to do some additional introductions. Start with people. No, you may not have heard this, but if you're joining online, if you could just please put your name and your affiliation and whether you'd like to testify in the chat. I think for the sake of time and with the number of folks that we have, we're probably not going to be able to go through this. So I'm going to go ahead and proceed with the meeting, and then we'll get back to the testimony part. All right. So procedure and notice. This is the time and place set for a public rulemaking hearing to receive testimony regarding, again, the adoption of Oregon Administrative Rule 836-053-0441, which sets requirements for health benefit plans coverage of gender affirming treatment services. Notice for today's hearing was published in the Oregon Bulletin on November 1, 2024. Notice was also mailed and distributed to insurers, to persons on the division's mailing list, and to other interested parties. A copy of the notice of hearing, together with the notice of proposed rulemaking and statement of need and fiscal impact is contained in the master file and is made part of the record. This hearing will be conducted according to the Oregon Administrative Procedures Act, Oregon Revised Statutes, Chapter 183, and Attorney General's Model Rules of Procedure. Written comments will be accepted until November 26, 2024 at 5 p.m. Pacific time. No other comments or exhibits will be accepted after that date and time. Brief background and history. House Bill 2002, enacted by the Oregon Legislature in 2023, expands access to gender affirming treatment through health benefit plans across the state. This legislation mandates that health insurers cover medically necessary gender affirming treatment when prescribed by physical or behavioral health care providers. What rulemaking does? The proposed rule establishes comprehensive coverage requirements for gender affirming treatment, including the following provisions. Coverage mandates. Health benefit plans may not deny or limit medically necessary gender affirming treatment as determined by the prescribing provider and in accordance with the accepted standards of care. One of them being WPATH Standard Care 8, version 8. Network adequacy requirements. Health benefit plans must ensure that enrollees have adequate access to gender affirming treatment providers without unreasonable delay. In accordance with House Bill 2002 and the rule, insurers are required to either contract with the network providers who offer gender affirming treatment and are sufficient in number and geographic location to provide accessible services, or ensure that enrollees who must access out-of-network providers for gender affirming treatment face no greater cost sharing or out-of-pocket costs than they would within network providers, thereby eliminating any undue financial burden for accessing these services. Provider training requirement. Reviewing providers must complete the WPATH Standard of Care 8 health plan providers training or an equivalent training program. This rule aims to ensure that all Oregonians have equitable, timely access to medically necessary gender affirming treatment as prescribed by healthcare providers and in compliance with recognized standards of care. So now it's time for public testimony. And we are taking a documentation of that here, and we'll decide how to get started. So let's take a moment, a pause for a moment. Sorry, room.
Yeah.
You want me to bring it? Let's do this. Okay. All right, well, we'll go ahead and start with the folks in the room that introduced themselves and stated they wanted to give some oral testimony. So Justine Prayer, you have the floor. And I'll just preface that because we have quite a number of folks today, if you could try to limit your testimony to 2 to 3 minutes, that would be great if possible. So I'm just giving everybody a heads up on that, just because of the timing.
Yes, ma'am. You want me to start?
Please, yeah.
Thank you all for having me here and giving me this opportunity. I greatly appreciate it. My name is Justine Detterling-Craer. I'm from Washington State, which has very similar policies to Oregon regarding what is called gender affirming care. I am a member of a medical watchdog organization regarding pediatric transition for gender dysphoria for concerned gay, lesbian, and bisexual citizens called Gender Health Query. This issue is as much a gay and lesbian human rights issue as it is a trans rights issue. All prior research indicates high rates of desistance from childhood clinical gender dysphoria, with many going on to be gay, lesbian, or bisexual adults if their gender dysphoria is not reinforced and they are not medicalized in puberty. We believe those who have transition regret is a growing cohort, and many of these individuals are same-sex attracted people who transitioned when they were teens or young adults. Altering the mind and body of a growing tween or teen is a human rights violation, as brain maturation is not complete until age 25. Some of the side effects from medical transition under age are permanently destroyed sexual function, pelvic floor damage, sterility, osteopenia, and possible negative impacts on IQ. Many once trusted institutions, the general public and parents have been manipulated into going along with this extreme practice due to activists in the health professions and outside of it promoting the unsubstantiated claim this is preventing suicide. They then engage in circular citationing of poor quality studies to manufacture consensus. Now on to what I want to really address here is the referencing of WPATH in this rule, and that is my main concern. So I will be specific here. WPATH has managed to pass itself off as a legitimate medical standards of care organization. It is not. It is an ideological one. It is an activist organization with extreme libertine views about body modification, including those on children at the crack of puberty. And they believe that this should all be funded via the government and private insurance. Their standards of care serve to promote this goal and to provide a cover for doctors against lawsuits and is not based on science-based medicine. We submitted a letter proving all of the claims that I'm making. WPATH is so extreme, they have participated in promoting the suicide narrative that better systematic evidence reviews have failed to prove, telling parents their kids are going to kill themselves when they do not have solid evidence that that is true. Who does that? Quality healthcare providers? WPATH is so extreme, their members have given tweens chemical castration drugs that they now state have permanently destroyed their sexual function. I'd like to remind everyone here, these are children between the ages of 11 and 13. Who does that? Quality healthcare providers? WPATH is so extreme, they included a unit chapter in their standards of care. These are people who've been known to have castration fantasies, and some of these individuals associated with some of these citations have fantasies involving underage children. So you don't want an organization that's associating itself with individuals like this when they are giving minors chemical castration drugs. I hope we all see why that's problematic. One of these members, Joanna Olson Kennedy, stated publicly that a teenage girl who later regrets a double mastectomy, that if she wants to have breasts later, she can, quote, go and get them. Who says that? Quality healthcare providers? WPATH is so extreme, they suppress data that counters their transition as cure for minors narrative. This involves research regarding Johns Hopkins and the National Institute of Health.
Excuse me,
All my
just-
claims are thoroughly documented by multiple sources. Thank you very much.
Yeah, we're kind of at time, and I appreciate that. And if you could please follow that up with in writing, we would.
Yes,
appreciate
we have. Thank you so much.
Okay.
Sorry if I went over
Oh,
time.
you were good. Okay, so I just want to regroup here before we proceed on the testimony. I have a few other things to say, and then we're probably going to circle back to our Rules Advisory Committee members. I should have gone to them first and give them an opportunity, and then we'll pick back up in here. I appreciate your patience with that. So I just also need to state that in this public hearing, the division will not be responding to any comments or questions. We're just listening to those that want to testify. After the close of the public comment period, I will prepare a report, a hearing officer report for review by the division administrator and the insurance commissioner as part of the formal rulemaking procedure. So just wanted to preface that on why we're here listening. So I'm gonna have you help me, Karen, on what order we want to
Okay.
go in.
Let's start with Seth Johnstone.
Okay, Seth Johnstone, if you could please state your name and your affiliation before you proceed. You have the floor.
Of course. Yes, my name is Seth Johnstone. I'm a member of the Rulemaking Committee for HB 2002, and I hold a role as the Transgender Justice Program Manager for Basic Rights Oregon. I want to share appreciation to the division for the following being established in the proposed rule. Number one, determining the current standard of care for insurers to refer to be in compliance with HB 2002, which was the goal of the Rule Committee. Establishing a minimum training requirement for those issuing adverse benefit determinations. Due to the difference in training to support trans and gender diverse populations in the U.S., this establishes one in Oregon across carriers to assure aligned information is received in utilizing standards for this treatment. WPATH GEI can and will provide a virtual course in Oregon that we have verified will be available before January of 2025, unless there are specific modifications for Oregon's division. And we recommend there at least be a clear requirement for reviewers to be enrolled early in the year, suggestion being by January 31st, 2025, if modifications are needed. Number 3, ensuring transparency for the patient if requested related to their adverse benefit determination in line with Oregon statute. And number 4, alignment with the network adequacy standards in Oregon, addressing access to out-of-network gender-affirming treatment providers when network adequacy is not met. Basic Rights Oregon acknowledges the lack of providers in specific areas of our state and are working collaboratively to address workforce development. In the meantime, our patients still deserve access to care. Basic Rights Oregon supports this proposed rule. Within this, we support the Sections 1B, establishing the minimum accepted standards of care in this field. We suggested the definition and rule adequately account for the current state of medical practice in the U.S., while also giving carriers and treatment providers the flexibility to bring procedures to members as they become part of U.S. evidence-based practice. I have a statement directly from WPATH on HB 2002, which I will submit in full to the division with my written comment. At this point in time, Basic Rights Oregon has provided in research that there are not other standards of care similar to comprehensive scope and rooted in evidence-based science. This year, we have seen a historic number of efforts nationally seeking to dismantle the basic healthcare access that certain states only just recently achieved. And I urge all of you, those are making decisions for this community, to listen directly to trans people themselves about the large amount of barriers that exist and to the people who take care of us. There is a lot of misinformation being created by people who are not transgender and who took interest in us out of the fear of the unknown. They do not share the goal of supporting this population's mental health and physical well-being. And there is, in fact, lots of data on this work, decades of research, and some of providers who I work with daily have produced very important components of it on patients across the lifespan who are in clinic today assisting patients, so aren't in this room, but submitting letters to you on behalf of this detailed research and work and the body of it that does exist. Lastly, I want to remind our decision makers that there are systemic denials of opportunity that prevent full participation in society for gender diverse people that the legislature passed this statute to address. It is not for this committee to debate the validity of transgender people or whether we should do this care in Oregon and for who. It is to promulgate rule for 2002 on how the law will operate for insurance carriers and their expectations to be in compliance. With the goal of addressing health inequities, HB 2002 became a necessity to bring our state insurers into alignment, create standard practice, and ensure coverage for gender-affirming treatment. This rule will allow the state to move forward. We appreciate the opportunity to work on this rule. This process is one step towards a healthier community supported by global evidence-based practices. For example, we see the LGBTQ population is pushed out of education environments, denied and unable to maintain employment due to discrimination, and their overall financial wellness is impacted by compounding effects, including paying out of pocket for decades for healthcare that remained uncovered until 2002. We are working to address health needs by addressing what factors contribute to poverty and houselessness, physical and mental health disparities, and a higher risk of violence, and this is one step in the direction of taking care of our community's health. Thank you for the time.
Thank you, Seth. And I don't want to have to interrupt anybody, but I would say that Justine and Seth were kind of right at the point of just about number 3, so that if you can kind of gauge that, that'll be helpful. So I can go to the next person. Any other RAC members?
Rick Blackwell.
Thank you. For the record, I'm Rick Blackwell. I'm the Government Relations Director for Oregon for Pacific Source Health Plans. Just want to speak really quickly to the rules themselves. First off, we want to note that Pacific Source believes the proposed rule impermissibly adds cost sharing to the interpretation of denial or limitations of coverage. Under Section 22A of the Act, coverage in its plain and ordinary meaning means the level of protection offered by an insurance policy. Limitations should be understood as applying the kinds of medical care reimbursable by the insurance policy. If the Assembly had wished to deny cost sharing as a limitation, they could have done so. And so we think that provision needs to be struck from the proposed rule. Next, we have remaining concerns on the requirements to train individuals with the insurance carrier on the standards of care. The Act itself does not require training, and by Act I mean House Bill 2002, does not require training of either providers who deliver care or reviewing peers within health benefit plans. Instead, the Act requires that a health plan have a person with experience prescribing or delivering gender-affirming treatment review and approve a denial for treatment. By setting those standards of care, a reviewer would already need to be trained to apply the standards. Anyway, obviating the need to require training in the rule. So we would implore the division not to adopt the unnecessary and out of scope training requirement. If, in the alternative, the division wants to consider some other method of ensuring that experience is shown by a carrier, we'd ask that perhaps the carriers can either show that a person has received training or they have the requisite experience under the standard of care. We'll provide some information in writing after the hearing on the wording language that we think would satisfy that under the rule. Finally, if either of those points aren't accepted by the division with respect to training, we would ask for enough specificity in the rule document itself to include a URL where we can access those training materials. So we know exactly what training standard the division is wanting us to apply. We also think that a reasonable time frame to obtain the necessary training, which is probably longer than that others would like, and will probably speak to, is warranted. I think probably that at least a 6-month window would be appropriate, just because we don't want to delay utilizations management in applying the standards that we have to. So with that, I will conclude my comments. Thank you very much.
Thank you.
Marlene Converse.
Hello, good morning. My name is Marlene Converse, and I am a government relations consultant for Kaiser Permanente. Thank you for the opportunity to provide comments on the proposed regulation and for including us on the Rulemaking Advisory Committee. We appreciate the collaborative approach taken throughout the rulemaking process. We are submitting written comments that have more detail. I'm going to try and keep this short in the interest of time. We do support the concept of decision makers having relevant experience in education. There's been a lot of back and forth in the rulemaking process about what the WPATH training is and how available it would be. It isn't clear in the proposed regulation which course is required. However, we understand that Oregon will be working with WPATH to create some training, but it's really unclear when that training will be available or what format the training will be in. And so because of that, it's almost Thanksgiving now, and the regulation currently would go into effect at the same time as the regulation for the training component would go into effect at the same time as everything else in the regulation. And we really think there needs to be time built in for health carriers to demonstrate that their staff has the appropriate professional experience or training in place and not be found out of compliance with the regulation. We have in our comment letter, we will address some language that we think would address this issue. And we do think that it would be helpful to have a list of acceptable training posted on the division's website so that all carriers and the public are aware of which courses would meet the requirements in the regulation. Thank you again for the opportunity to comment at today's meeting.
Thank you, Marlene.
Scott White.
Good morning. My name is Scott White, and I'm the Director of Regulatory Affairs for MOTA Health. Thank you for the opportunity to provide oral testimony at today's hearing, and thank you for the opportunity to participate in the Rulemaking Advisory Committee for Oregon House Bill 2002. My testimony today will be focused on concerns that MOTA has relating to the stipulation in the proposed rule that requires a provider who is reviewing and approving adverse benefit determinations to complete a supplemental WPATH SOC 8 health plan provider training or an equivalent training program. MOTA supports the House Bills 2002 and associated rule requirements that gender-affirming treatment services must be reviewed by providers who have experience in prescribing or delivering gender-affirming care treatment. However, MOTA has concerns about the need for an additional specific training requirement outlined in the rule and the number of still unknown factors related to this training. As such, MOTA has the following recommendations. MOTA recommends that the DFR remove the WPATH SOC 8 health plan provider training program or equivalent training program requirement from the final rules. Oregon House Bill 2002 does not prescribe or require provider training or certification in WPATH. The bill requires that a provider with experience prescribing or delivering gender-affirming treatment review and approve any denial or limitation to treatment access. The final rules we're discussing today add to the House Bill 2002 provision by clarifying that the reviewing provider must also have experience utilizing WPATH. These two requirements are sufficient to ensure that benefit determinations related to gender-affirming treatment services are reviewed by providers who have experience prescribing or delivering such services. Given the provider requirements already in place, any additional training requirement that only applies to providers reviewing these services and not to providers prescribing or actually providing these services is an unnecessary administrative burden and ultimately sets higher standards for the reviewer than the actual provider of care. MOTA also has concerns regarding communication sent by the DFR to members of the Rulemaking Advisory Committee, which state that in order to align this training with Oregon's specific needs, the Division of Financial Regulation will collaborate with WPATH to adopt and modify the curriculum accordingly. Oregon House Bill 2002 does not require or grant the DFR the authority to create or collaborate in the creation of any gender-affirming care treatment training or training materials. Any required training should be created by an independent body of medical professionals with the appropriate qualifications, not the Division of Financial Regulation. This logic also applies to the determination of WPATH training program equivalency. Equivalency training should be determined by medical professionals and not by the DFR. For the reasons listed, MOTA recommends that the DFR remove the WPATH SOC 8 Health Plan Provider Training Program or equivalent training program requirement from the final rules. While MOTA believes that this option is the best aligned with the intent of House Bill 2002, if the DFR retains the training program, MOTA recommends giving reviewing providers at least 18 months from the effective date of the final rule to complete such training, given the number of unknowns such as content of the training materials, completion date of the training, availability of the training format, webinar, module, or in person, the associated cost for the training, and which trainings would be considered equivalent. Thank you for your time and the opportunity to speak today. I will follow my testimony with detailed written comments. Thank you.
Thank you, Scott. Antoinette.
Good morning. My name is Antoinette Iwachi, and I'm the Senior Public and Regulatory Affairs Consultant at Regions Blue Cross Blue Shield of Oregon. I will do my best to limit my testimony to 2 to 3 minutes. First of all, thank you for the opportunity to be part of the Rule Advisory Committee and to testify on the gender affirming treatment proposed rules. My comments will focus specifically on the training requirements for providers reviewing adverse benefit determinations and the compliance date. A comment letter will be submitted supporting my oral testimony. First, the underlying legislation, House Bill 2002, which the rules implement, does not include a training requirement for providers who review adverse benefit determinations. House Bill 2002 only requires, and in quotation, a physical or behavioral health care provider with experience prescribing or delivering gender-affirming treatment, close quotation, to first review and approve the denial of or the limitation on access to the treatment before a carrier can issue an adverse benefit determination. It does not require such providers, prior to submitting an adverse determination, to demonstrate their experience by having completed the WPATH 8 Health Plan Providers Training Program. Therefore, we believe the requirement goes beyond the scope of the mandate and request that the provision be removed. Second, it places training requirements on reviewing providers when such requirements do not exist for providers performing the service. So requiring providers who review adverse benefit determinations to have experience utilizing WPATH 8 is appropriate under House Bill 2002. However, imposing training requirements on reviewing providers when such do not exist for providers who perform the services exceeds the scope of the mandate and is not sound policy. Familiarity with the utilization and application of the publicly available guidelines does not require taking a training course. It is requiring the reviewer to meet a higher standard than the provider of care, which does not support access to public safety or access to care for patients. Third, it applies beyond independent review organizations. The rules do not have any provisions for training of those reviewers who approve the requested treatments. It only addresses those reviewers who submit an adverse benefit determination. This would apply not just to independent review organizations, but all of health plan internal medical directors would need to also take this course. We do not believe this is necessary. It increases costs for insurers and it exceeds the scope of the legislation. Lastly, independent review organizations will not have the ability to require their reviewers to take this course at their expense, as this is something that do not need to practice, or they do not need to practice medicine, nor is this needed to do peer reviews in other states. With respect to completing an equivalent training program, should the DFR move forward with the requirement, we request that the DFR collaborate with payers in identifying a list of acceptable equivalent training programs, which the DFR can post on its website. These trainings should not impose a multi-year training requirement on providers who are already licensed and familiar with WPATH SOC 8. Lastly, the June 1st, 2025 compliance date in the DFR's email to payers last week. If the DFR moves forward with any training requirement, we strongly encourage it to consider a January 1st, 2026 compliance date, which would give us about an 18-month lead time, given the DFR has yet to meet with WPATH to adapt and modify the curriculum, and the DFR does not know yet what it will entail. In addition, after the curriculum is completed, we would like the DFR to give payers the opportunity to comment on it and have adequate time to implement it. So in conclusion, given these concerns, we strongly urge the DFR to remove the training requirement from the rule, work with WPATH and payers on an acceptable curriculum, and then reopen the rules by way of a rules advisory committee to address any training requirements. As noted in our previous comment letter, while the intent of the additional requirements in Section 5BC are a good thought, they are not necessary, will limit access to care, and impose a requirement that is not required to practice medicine. For these reasons, we request that these sections be removed with respect to the Cronin program in its entirety until training requirements are thoroughly vetted out. Thank you.
Yeah, I think, Amy Perkin, I think you're a RAC. Amy Penkin, I'm sorry.
Penkin. Yes, hi. My name is Amy Penkin. I use she, her pronouns. I'm a licensed clinical social worker and a Rules Advisory Committee member. I am testifying in support of the rules as written established to provide clarity and implementation of House Bill 2002 for insurers to be in compliance. I support establishing the training requirement and clear definition in affirming treatment for those who will be issuing adverse benefit determinations, and believe this is in alignment with the intended and spirit of House Bill 2002. I had the opportunity recently to meet with WPATH leadership with my colleague Seth and confirm they have generated a course specifically designed for health plans and have already successfully been using these plans in California. This training is nearly ready to launch and is easily adaptable to the needs of Oregon and will help those making adverse determinations be well informed about gender affirming care. As a provider, I've seen countless denials issued by those who don't have an adequate understanding of gender affirming care and SOC 8. This component of the rule will ensure appropriate determinations. I will follow my testimony with written comments. Thank you.
Thank you.
And I do apologize, I don't have my list in front of me of all of the committee members. Have we missed somebody that is in attendance? Yes, all right. I recognize that name. Yeah. Go ahead.
Thank you. Thank you all for allowing me to share my testimony today. My name is Everett Redente. I'm a member of the Rules Advisory Committee here. I'm also an advocate, licensed clinical social worker, and a transgender community member, and I live in Portland, Oregon. In addition to my own lived experience, I see the benefit and importance of gender affirming care access every day in my work as a social worker that serves transgender and gender diverse Oregonians exclusively. I'm asking you to support this proposed rule as is and keep Section 1B, which establishes the WPATH Standards of Care version 8 as the accepted standards of care for gender affirming treatment at a minimum. The WPATH excuse me, standards of care were first published in 1979 and have been updated 8 times over the last 45 years to reflect the progress and advancements in gender affirming care in medicine. The most recent version of the Standards of Care, SOC 8, was published in 2022 and developed using an evidence-based approach. The evidence review team at WPATH conducted international systemic reviews of the most current data and studies on gender affirming treatment and spent years working on these standards of care to provide the best clinical guidance for health professionals working in this field. The House Bill 2002 rulemaking process intent is not to debate the validity of gender affirming treatment, as some who seek to dismantle gender affirming care access may testify and submit letters about in this public hearing. The purpose of this RAC is to establish a clear definition for House Bill 2002 that was passed by the legislature so that insurers understand the expectations to be in compliance with the law. If the WPATH SOC 8 is not included, payers can choose a standard of care that does not follow as rigorous of a evidence review process, or is outdated or intentionally spreads misinformation about what gender affirming treatment is and is not. Due to the state of anti-transgender rhetoric, attacks on gender affirming care access, and lack of information and education within medical schools, having a shared standard of education on transgender health is essential. As someone who reviews prior authorization denials for gender affirming treatment in my professional job, not all experience in providing or prescribing gender affirming treatment is created equal. If WPATH SOC 8 is the standard of care we are following, it is essential that professionals making adverse determinations with the payers understand and be familiar with WPATH SOC 8, which the proposed training in the rule would provide. House Bill 2002 has already helped close coverage gaps in life-saving gender affirming care access for transgender Oregonians. We have the opportunity to provide clarity for House Bill 2002 for our insurance carriers to ensure proper implementation of the law. By supporting the proposed rule in its current form, you'll be protecting access to medically necessary, equitable healthcare for transgender Oregonians. Thank you.
Thank you. So we are going to come back to the room here and offer the opportunity to Jamie Reed to testify, and then we'll go back to the online testifiers. And then when I do go back to the folks that are joining virtually, I think what Karen and I will do while we are running the time clock, we'll just raise our hand just right around the 3-minute mark, so you know that you hit the 3-minute mark, and if you go a little bit over, I don't have a gavel. I don't, I just think I should raise a hand and give you an indication. So that might help us a little bit. And just a reminder to please provide a copy of a summary of your oral testimony in writing to Karen Winkle. So we can go ahead and you have the floor, Jamie.
Good morning. I appreciate the chance to speak with you today. My name is Jamie Reed, and I'm the Executive Director of the LGBT Courage Coalition, a national coalition of adults from this community. I am a lesbian, and my legal spouse is a detransitioner. I hold a Master of Science in Clinical Research Management from Washington University, and I am also a publicly legally recognized whistleblower from the Pediatric Transgender Center industry from St. Louis, Missouri. My organization has retained counsel and has been monitoring closely this developing situation in your state. I wish to today provide you with firsthand experience from inside of a gender center regarding how WPATH is used. WPATH is an advocacy organization that is well known to those working in this field. WPATH guidelines were written through a process called the Delphi Consensus. This is not an evidence-based program. This is not led by science, but this is led by rather those who have the loudest and most persistent messaging. The use of WPATH guidelines by the state of Oregon is going to be telling gender-distressed young people, many of whom would otherwise grow up to be gays and lesbians, and their families, that they are second-class citizens. That you are accepting that harmful, non-evidence-based treatment guidelines are somehow acceptable because my community is different. This is not okay. My community deserves the exact same standard of care and medical evidence that is afforded to the general public. WPATH does not meet this standard. If Oregon adopts WPATH as the standard of care, we believe that you will actually be discriminating directly against my community, and we will fight it. We ardently believe that those who experience gender distress regarding their sex bodies and this concept called gender deserve the exact same kind of evidence-based treatment guidelines like the rest of the general public. This is the double standard, and we will not accept this in any other medical arena. The only guidelines in the world currently that would meet the standard of care are from the countries of Finland and Sweden, and they are readily accessible and able for you to utilize. These are evidence-based practices from the international community, and this is not what WPATH is proposing. WPATH guidelines were used in the center where I worked for almost 5 years. I counseled minors who had irreversible harms to the intervention that WPATH lays out, including young people who had such severe vaginal lacerations due to the early use of testosterone that they were required to have emergency surgical repairs. WPATH has written its guidelines in such a way that allows for everything and restricts nothing, which is exactly why they are asking you to utilize WPATH as the training program regarding adverse determinations. It is to ensure that the insurance companies cannot provide any safekeeping. We understand that you're required to implement the law that was passed, but its implementation does not require that you use or reference WPATH. We also believe that within 5 years, we will all look back on this law itself and recognize that it was unethical and harmful to be giving any of these interventions to young people. Thank you for your time. Thank you. Thank you.
Have I missed any of the committee members? Thank you. All right, we will go back up to our list of. Okay. 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 So next is Paul Turdahl.
Hi, can you hear me okay?
Yes.
Great. Hi. So I'm Paul Turdahl. I'm a sort of health consumer advocate and a member of the Division's Insurance Advisory Committee representing consumers. I have a couple of key comments that I want to put in. First, House Bill 2002 should really be interpreted as something that reinforced and preserved existing rights under existing state and federal law in Oregon. Everything listed in there in terms of medically necessary care for gender distress should already have been required in Oregon under Bulletin 2 since for the last dozen years, since 2012-1, 2014-1, 2016-1. All of those bulletins already clearly laid out everything that was required in this bill. It should not be considered a new mandate for new services so much as reinforcement and reiteration, maybe like consolidation under different statutes into a single place for consistent enforcement and compliance. And also potentially a preventative in case federal law change that might weaken services in the future. That was a great service and community to those who depend on this care. What it did not do, absolutely did not do, is empowered the division to pick and choose clinical standards for treatment of gender distress. The bill and the legislative history was extremely clear about delegating that clinical decision-making authority to the prescribing physician and to the carrier medical directors, provided they have the appropriate experience. That's it. If the prescribing clinician prescribes something, that goes forward. If the carrier's medical directors who have appropriate training have concerns, they can issue an adverse benefit decision based on medical necessity or experimental investigational issues. And that, through your normal process, goes to an outside medical expert with appropriate qualifications to resolve it. That's it. That's the end of your responsibility when it comes, and authority when it comes to medical decision making. By stepping in and identifying, picking and choosing one association's clinical process and clinical guidelines, you're really overstepping your authority. You're risking invalidation of the entire rule. And you're picking, as some of the other people have testified, you're picking, well, actually, as you yourself identified, discussed in the August RAC meeting, you yourself told the RAC, hey, the division recognizes that many of the procedures listed in WPATH are not actually commonly performed in Oregon at all. And you yourselves told the RAC you recognize that many of the services listed there may be experimental or investigational. By encoding that document into the rule, when you yourselves know that it contains things that are not at all commonly done, maybe experimental, you're really confusing the public. You're confusing health consumers who will be under the mistaken impression that you have validated and certified that WPATH is true and good. You are confusing physicians who will believe that everything in there is good to go when you've already told the carriers that they're free to buy anything in there. And you're confusing judges who will be making decisions because they will think, hey, anything in WPATH has got to be, standard of care in Oregon for purposes of medical malpractice, when you again haven't actually done that. So this is super important. The last comment I'm going to make before I wrap up is about detransitioners. Commissioner Stolfi made a specific written commitment to the legislature that he would address detransitioners in this process. I tried to help you find a detransitioner who would join this RAC and help you with that process. Unfortunately, you refused her participation. And again, that was an Administrative Procedures Act violation by not directly including that stakeholder group. And so I'd really encourage you to work with detransitioners to address that and fix that. Thank you.
Thank you.
Okay, Stephanie, Wynn.
Thank you for the opportunity to speak. I urge you to resist the pressure from activists to enshrine into Oregon law the misleadingly named and highly contested WPATH standards of care. These deviate significantly from traditional standards of care in that they were designed by activists and not based on high quality, objective medical evidence, as clearly shown in the WPATH files released last year by Environmental Progress, which I urge you to read. I'm a licensed marriage and family therapist who has treated patients harmed by these so-called standards. The proposed rule leaves these patients abandoned without treatment for iatrogenic harm. Prior to hearing the stories of detransitioners, transition regretters, and families torn apart over this issue, I acted in good faith under the naive yet common misunderstanding that there was an objective way for professionals to accurately predict which patients would truly be better off transitioning. I now understand there is no objective way of determining who will persist in their gender dysphoria, that most people will desist after several years, that nearly all patients referred to gender clinics are moved through a one-way conveyor belt, and that so-called gender-affirming care permanently harms patients, including vulnerable young adults with histories of trauma. I had been taught that patients who identified as trans were at elevated risk of suicide if they were not able to transition, and that the drugs and surgeries they were prescribed in the name of gender-affirming care would lead to better life outcomes. I now know the opposite is true. I regret the role I played in former patients' transitions. I humbly urge my colleagues to reconsider their stances and consider the consequences of the possibility that they might be wrong. The fact is that gender-affirming hormones and surgeries are associated with significantly elevated all-cause mortality, including higher rates of cancer, cardiovascular and metabolic diseases, as well as greatly increased risk of suicide after transition. This is the opposite of what I was taught by activists. Yet it's not surprising when you take into consideration that chronic pain, disability, and loneliness are amongst the greatest overall risk factors for suicide. Gender-affirming drugs and procedures create chronic long-term pain and disability while altering patients' sexual functioning in ways that reduce their chances of forming relationships and families. Puberty blockers impair bone and brain development during a critical developmental window, leading to lifelong cognitive, emotional, and osteoarthritic problems. Children whose puberty is blocked at Tanner stage 2 will never achieve full sexual functioning, including the abilities to orgasm and to reproduce. There is no way for us as reproductively intact adults to comprehend how incredibly depressing this experience can be and how humiliated these individuals will feel as they age because of decisions they were enabled to make at age 10. Males taking testosterone-suppressing drugs such as spironolactone plus female sex hormones such as estradiol lose gray matter in the brain, increasing their long-term risk of all kinds of psychiatric and neurological problems ranging from depression and anxiety to psychosis and early Alzheimer's. Indeed, overall patient consumption of psychiatric drugs goes up rather than down after receiving gender-affirming treatments. We would not expect to see this result if the procedures were effective at improving mental health. Meanwhile, these drugs rob them of their fertility. I've spoken with several individuals and families impacted in this way. Despite the fact that brains do not reach full maturity till the mid-20s, the WPATH standards of care would allow this kind of life decision to not have children to be made at any age. Similarly, cross-sex hormones can be sterilizing for females and cause their urogenital systems to atrophy and morph in numerous painful and embarrassing ways, ranging from clitoral growth that causes unavoidable chafing to painful orgasms, pain and bleeding with vaginal insertion, urinary incontinence, and even fecal incontinence. All right, I'm just going to skip ahead to say the proposed rule does not provide coverage for those harmed by these unnecessary experimental life-shortening interventions, and we must look out for the needs of detransitioners and prevent more people from going down this painful, irreversible pathway. Thank you.
Thank you, Stephanie.
Emily Newberry.
Yes, my name is Emily Newberry. Excuse me, I have a cold. And I played a small role in convincing the Centers for Medicare and Medicaid Services to stop denying care through the Medicare and Medicaid programs, because even though I was able to raise funds for my own care and surgeries, I knew that there were a lot of people who did not have access to it. My actual real life experience is that the hormones and the surgery that I got were life-saving. They made my life infinitely better and happier. And after years of living on estrogen, I am actually a happier and healthier human being. And but that doesn't change the fact that we need to do healthcare in a responsible and scientific way and constantly be improving. I worked for a number of years for Kaiser Permanente, onboarding, training, and mentoring patients who served as advisors to work with staff, medical staff, to improve the care that was already being delivered, including helping to build the Gender Pathways Clinic for transgender care and supporting a patient advisory council to be sure that the care was being done in a way that really worked for the patients. I agree with several of the people who have testified today that this rule, if and when implemented, should be a bit more open and easier to change and implement, to give people time to do any training that's needs to be done, and to make sure that more than one, more than one type of class will be implemented. Again, in the interest of making sure that on an ongoing basis, we continue to provide the best care. Thank you.
Thank you.
Felix, is it Noble?
Yes, thank you. I'm Felix Noble, speaking on behalf of Oregon Consumer Justice. We help participate in the Rules Advisory Committee for HB 2002. We would like to express our support for the inclusion of WPATH 8 as the baseline for accepted standards of care. Individuals seeking gender-affirming care deserve the peace of mind that healthcare providers meet minimum requirements to practice in this field. Further, we would like to reiterate our concern about the ambiguity implied in the network adequacy standard without unreasonable delay. Such ambiguity could lead to long wait times, which uniquely and adversely impact the health of those seeking gender-affirming care. While future rulemaking seeks to define on a statewide scale the meaning of unreasonable delay, the term may rightfully have a different meaning in the context of gender-affirming care. Longer wait times can have a great impact on the quality of life for those seeking gender-affirming care, making the threshold for what constitutes unreasonable lower in this context. We thank you for your time and consideration today, and we'll keep it short.
Thank you.
All right. Camille, I don't know how to say your last name. Keeple? Keipel?
People.
Thank you.
Right.
Please go ahead.
Yeah, Keeful. Yeah, thank you. Yeah, thank you for having me here today. Let's see here. My name is
We can hear you.
Okay. My name is Camille Kiefel. I am a detransitioner and president of Detrans Help, an organization that provides resources to detransitioners. I'm here today to address my concerns over WPATH Standard of Care 8 being the standard of care for insurance guidelines, given my experience assisting detransitioners and struggling to get care as a detransitioner myself. WPATH Standard of Care 8 openly admits they know very little about detransition. They say it's rare, and they seem more concerned with detransition negatively impacting trans care rather than acknowledging those harmed by transitioning. Regret is not a gender journey. It is painful. In my role as Detrans Help, I've reached out to WPATH to start a dialogue. WPATH did not respond. I've seen the consequences of WPATH Standard of Care 8 and detransitioner care firsthand. One detransitioner dealing with chronic health issues from hormone therapy reached out to us for getting help access to testosterone, which he can no longer produce because of genital reassignment surgery. His endocrinologist and primary care physician forced him to continue estrogen therapy. Planned Parenthood would not treat him, but why is it that Planned Parenthood provides care to trans individuals but not detransitioners? This detransitioner told me that when you mention detransition to your physician, it automatically brings up WPATH guidelines, which makes them hesitant to intervene. Detransitioners should not be afraid to tell their doctors that they are no longer trans identified. This is a serious issue. I know too many detransitioners who have struggled to get the care they need after detransitioning because there's no infrastructure to support us. For instance, Abel Garcia was forced to live as a woman after he detransitioned. Therapists denied him care, citing internalized transphobia. They were forcing him to stay as a sex he no longer identified with. Some detransitioners, like myself, have trouble getting care since we are now considered cisgender. When you decided that Standard of Care 8 would be the standard of care, how many detransitioners did you consult? How many are on your board? By law, detransitioners, like trans folks, are a minority and a protected class. Denying detransitioner care is discriminatory. The policy you are creating will lead to discrimination lawsuits. Detransitioners matter. We have the right to access good medical care and have the harm done to us acknowledged.
Thank you.
Isaiah Bartlett.
Hi, my name is Isaiah Bartlett. Hold on, let me get my document. All right. My name is Isaiah Bartlett, and I am a licensed clinical social worker and psychotherapist in private practice in Portland. I've been a therapist for over 10 years and worked almost exclusively with trans and non-binary communities. During this time, I've seen firsthand the impact that gender dysphoria has on mental health, as well as helped clients navigate the often exhausting amounts of red tape in order to access transition-related healthcare.
2 weeks.
I am here on behalf of my clients and my community as an openly transgender therapist who has also received life-saving medical care that I am advocating for. Oregon is already a leader on transgender healthcare access. Over and over in my practice, I meet with clients who flee other states all over the country and specifically come to Oregon because of the protections we have in place for trans people and the number of qualified healthcare providers we have here. In the current political climate, I expect this to increase dramatically.
So much.
Since 2015, the Oregon Health Plan and private insurers have covered certain gender-affirming care procedures. The insurance mandate for gender-affirming treatment through HB 2002 addressed many of the gaps in coverage. Oregon has become a leader in providing care that is crucial for many transgender people, including electrolysis and hair removal necessary for certain surgeries and patient safety, and facial affirmation surgeries that have been historically and commonly denied. The HB 2002 rulemaking process intent is not to debate the validity of gender-affirming treatment, as some may submit letters about this in public hearing who seek to dismantle gender-affirming care access. was to establish a clear definition for HB 2002 that was passed by legislature so that insurers understand expectations to be in compliance. In my clinical work, I've watched countless clients, particularly transgender women, be denied gender-affirming healthcare by insurance companies who label this care as cosmetic and not medically necessary. In response to this, these clients often become depressed, isolated, hopeless, and end up internalizing narratives that their need for safety in their own bodies is not valid. I've also watched these denials lead to continued lack of trust with medical systems at large and discourage clients from seeking other forms of healthcare for fear of discrimination and/or not being taken seriously. As a patient, I've also been denied gender-affirming care by a local Oregon-based insurance company. I spent over a year fighting the insurance company and time-consuming appeals and sent over 1,000 pages of legal and research-based documentation citing medical necessity for gender-affirming care. Even with all of this, I still lost and had to pay bills out of pocket. If this legislation had been in effect at that time, it would have helped me avoid this unnecessary cost. By supporting this proposed rule in its current form, you'll be protecting access to medically necessary, equitable healthcare for transgender Oregonians. Please remember my story when you finalize this draft into rule. Thank you.
Thank you.
Olivia H.
I'm submitting a written testimony.
Oh, I'm sorry. Okay. Okay, all right. So Jennifer Kennedy. Oh.
Okay. You might need to unmute yourself, Jennifer. Sorry about that.
Okay, everyone can hear me?
Yes, now we can hear you.
Thank you so much. Good morning. My name's Jennifer Kennedy. I'm an attorney for Our Duty USA, which is a nonpartisan, non-religious international group of parents protecting children from gender ideology. And the rule today is being considered today is reckless, it's unsupported, and it's dangerous. And it far exceeds what the legislature authorized in House Bill 2002. As we know, that bill required Oregon insurers to cover medically necessary care prescribed by licensed healthcare providers for so-called gender-affirming care. But I echo Paul Trudell, who earlier said that definition of medically necessary must be made by the medical community and not by radical activists. And yet that's what this rule would do by enshrining the WPATH 8 document as the accepted standard of care. I also echo Jamie Reed. The WPATH 8 document was developed not by a medical body, but by an advocacy group, transgender activists, and heavily influenced by their radical political agenda. And this agenda has been covered globally in the New York Times, The Economist, and recently even in a brief to the US Supreme Court. I echo Stephanie Wynn. The leak of those WPATH files earlier this year exposed massive medical negligence and a shocking disregard for the health and well-being of people experiencing gender distress, including children. And to date, nearly 2,800 medical professionals have signed a declaration stating that the WPATH has discredited itself and has denounced WPATH as unethical, not evidence-based, improvised, experimental. As earlier mentioned, some of the shocking specifics identified in the WPATH leaks include creating a new gender identity for eunuchs, specifically promoting the affirmative care model that is being abandoned globally, especially for the rising scientific skepticism that has led Sweden and Finland and France and the UK to retreat from that model. WPATH also endorses early medicalization as fundamental, while these other countries are now not doing that. And other things in the WPATH files that were released were a chapter on ethics that was erased, a definition of detransition that fundamentally mischaracterizes detransition. And from this declaration, while presented as being evidence-based, the WPATH standards of care fail to acknowledge the growing evidence that gender-affirming treatments in youth are of low quality and subject to bias and problematic conclusions about whether they are of any help at all. So from the declaration again, they say, for these and other reasons, we believe WPATH can no longer be viewed as a trustworthy source of clinical guidance in this field. So here we are where we have this proposed rule seeking to enshrine only the WPATH 8 as the accepted standard of care, which is shocking. Neither the insurance commissioner nor his staff possess any medical expertise or license. The commissioner is not empowered to regulate healthcare nor create legally binding standards of care for people experiencing gender distress. And at a minimum, approving this rule as drafted is going to invite lawsuits on that very topic. But worse, this rule and adopting the WPATH 8 will endanger vulnerable people and children. HB 2002 is bad enough. It allows children to make life-altering decisions about their bodies that cannot be reversed. But relying on the disgraced and radical WPATH as the accepted standard of care would help perpetuate what is truly the most heinous medical scandal of our time, namely the sterilization and mutilation of generations of children. And finally, echoing everyone who said this, it excludes detransitioners improperly, and it is silent as to detransition care. That silence says all you need to know, that this rule cannot be passed in its current form. Thank you.
Thank you. We'll address a question in the chat here once we're done with oral testimony.
Catherine, go for it.
Hi, my name's Catherine Goforth. I'm a resident of Portland, Oregon. I'm an opera singer and artist trained at the Juilliard School and Oper Köln in Cologne, Germany. And I've been nationally and internationally recognized for my work in classical music. I'm an adjunct professor at Clark College in Vancouver and a former adjunct professor at Reed College. And I'm also a transgender woman receiving gender-affirming healthcare in Oregon. I'm asking you to support this proposed rule and keep Section 1B, establishing accepted standards of care for this field, WPATH Standards of Care version 8. The World Professional Association for Transgender Health has its roots in the Magnus Hirschfeld Institute for Sexual Research in Weimar, Germany, over 100 years ago. It was one of the first clinics internationally to conduct research that supported the normalization of LGBT people before it was destroyed by the Nazi Party. Many of us who are gender and sexual minorities grow up believing that we are better off dead. I certainly did. Those teachings have had a lifelong impact on me. The original aim of this scientific work that WPATH continues is to let gender and sexual minorities know that who we are by nature is okay and normal, and we deserve to live our lives and be happy. I understand that insurance companies are concerned about how much this care might cost and whether they are ill-prepared to provide it. While I would love to pay for my care out of pocket, the reality is that transitioning has made it harder for me to find work and harder to make money. Discrimination against transgender people means that without insurance coverage, I will probably never be able to access the care I need to live a full life. When I hear insurance companies talk about how long they need to implement new programs, I think about those as years of my life. It took me decades to come to terms with the self-hatred that my society taught me before I learned that there was something I could do about it. But then after starting my medical transition in 2018, I'm still waiting for my first surgeries. The reality is that for those of us who want to live the same kind of lives as cisgender people, who want to participate equally in society, who want the same treatment and same opportunities, we need care that is aligned with WPATH version 8. Really, we need more care than WPATH version 8 covers, but it's still a good start. I don't know whether the personal suffering of transgender people is important to this committee or not, but I would just like you to know that waiting and waiting and waiting is agony for me. Like any person who requires medical care to heal, I just want my care. The more I have to wait, the more society has to wait for all the things I have to contribute. Please don't put any more barriers in the way of that. I just want to live my life, and so does every transgender person.
Your testimony. So I'm going to offer Jesse O'Brien, our policy section manager, an opportunity to respond to the comment, and then we can look into closing.
Yeah, just briefly, there's a comment in the chat questioning how to address issues raised in other people's testimony. And just process-wise, I wanted to clarify that just as we do not engage in a back and forth with testifiers, we appreciate that testifiers not engage in a back and forth with each other in this setting. It's not a public debate forum. If people are interested in making comment related to issues raised during the hearing, they are welcome to submit that in written comment. We will be taking written comment for another week here. And we take any writing that anyone submits. There's no particular parameters around that. So it could address what's in the hearing. It could address anything else that's on your mind.
Thank you, Jesse. Did we miss anyone? Is there anyone else that wants to make public comment, oral comment? Hearing none. Just a reminder, once again, written comments will be accepted until 5 p.m. Pacific time, November 26, 2024. No other comments or exhibits will be accepted after that. After the close of the public comment period, I'll prepare a report to submit to the administrator for review. The time is now 12:13 a.m. and so this concludes the public hearing. Thank you for being here. Have a good day.
It's 12:13 p.m., not a.m.
It's a p.m. p.m. Oh.